This particular audiocast will cover two topics: hormonal contraception and breast cancer, and challenges faced by the use of the so-called LARC methods. The areas that we'll discuss relative to breast cancer is whether the use of oral contraceptives increase the risk, and this would include actually the ring as well as the patch. Does the presence of a BRCA mutation change that risk? And do progestin-only contraceptive users have an increased risk of breast cancer? It's important to keep in mind there are multiple factors that lead to the early development of breast cancer. These include genetic factors as listed, growth factors, including both estrogen and progesterone, as well as tissue factors, such that for an epidemiologist to tease out the contribution of oral contraceptive use in a disorder that has multiple risk factors is sometimes challenging. It's also important to recognize from the time that you actually develop the cancer to the time it's diagnosed may be 6 or 7 years. This lends support, obviously, to the current approaches to screening, but also from an epidemiologic standpoint, creates some challenges, because if you're doing a study that involves looking at women who have breast cancer, say today, that in fact it may not reflect pills or other hormonal products in use today. It may reflect what was used 6, 7, or even longer years ago, and that's another important area that an epidemiologist has to deal with. If you look at the study of oral contraceptives and the risk of cancer, there are 3 studies that I think are particularly classic. One was done 20 years ago, involved 54 studies. And the evidence in that particular meta-analysis suggested that oral contraceptive users aged less than 35 have only a slightly higher risk of being diagnosed with breast cancer, and the risk declined over time. In fact, by age 50, the diagnosis or the risk of diagnosis of breast cancer was the same in both OC users and non-users. Further, there is no evidence that oral contraceptives, even higher dose ones, increase the risk of breast cancer even with increasing duration of use. Family history did not appear to modify the risk, and it was important to recognize that the findings could be due to detection bias, due to more frequent exams in a pill user, or may reflect that the pills were only promoting growth of pre-existing tumors. The second study, done about 10 years later, was a case control study. I was fortunate to be involved in that study as an investigator. Here, we used population controls as opposed to hospital controls, and this is felt to be perhaps more reflective of the general population. Data was collected from SEER registries between 1994 and 1998. As shown, both cases and controls had used oral contraceptives in fairly high amounts, but importantly, no risk of breast cancer was identified in women who had ever used any type of oral contraceptive. And among women between 35 and 64, current or former oral contraceptive users were not associated with an increased risk of breast cancer. There is no increase in risk for longer periods of use or higher doses of estrogen. Initiation of the pill at a young age was not associated with increased risk, and a family history of breast cancer was not associated with increased risk. Finally, the last study done or completed just a few years ago involved 23 studies in a meta-analysis, same type of results. Minimal increase of breast cancer among every users, and the risk decreased over time. There was no effective duration use, and in fact, the approximate increase in lifetime risk of breast cancer among oral contraceptives was less than 1%. What about the highest risk women, the ones with BRCA1 and 2? Paucity of data in this area. In this meta-analysis done a few years ago, 5 studies were looked at, were felt to be adequate, and were used in the meta-analysis, and the overall risk identified was similar to the studies that we've just discussed, such that it looks like these patients are not dramatically different than patients who have a different type of risk. There is also no effective duration, but the overall data was inadequate to look at positive family history and its effect on breast cancer risk in this population. Similar to the BRCA1 and 2 data, progestin-only contraceptives have also not been studied adequately, and in meta-analysis completed in 2016, only 6 articles were felt to be worthy of doing a systematic analysis. 5 of the 6 articles have reported no association between use of any form of progestin-only contraceptive and breast cancer. However, clearly there's a need for more rigorous studies due to small sample size, variation in the progestin's route of administration, and variation relative to the heterogeneity of study locations. So to answer our questions, does the use of oral contraceptives increase risk of breast cancer? Minimal, if any, increase. Does the presence of a BRCA mutation change the risk among pill users? No. Does the use of a progestin-only contraceptive increase the risk of breast cancer? Probably not, but more data is needed. Our second area that we'll talk about are the LARC management challenges. And the areas that we'll discuss are painful IUD insertion, missing IUD strings, non-fundal placement of an IUD, a positive pregnancy test with IUD use, and a non-palpable implant. In terms of management of painful IUD insertions, the data to date suggests there's not an ideal approach. A Cochrane review concluded recently that lidocaine gel, nonsteroidals, and misoprostol were not effective in reducing insertion pain in nulliparous women. The effectiveness of a paracentral block is variable in studies. Sometimes it works, sometimes it does appear to reduce pain with tenaculum placement. However, one could consider using misoprostol or a paracentral block when you know you've got a difficult insertion to carry out. What do you do when you have non-visualized strings? If a patient calls you in, let's say on a Friday afternoon, you got to certainly counsel her to use some backup method until you can evaluate her. Once you have her in the office, sweeping the cervical canal with a cytobrush is helpful. If you see the strings, basically she then undergoes routine care. If you don't, you rule out pregnancy. You can offer emergency contraceptive if indicated and have her use a backup method until you can complete an ultrasound. If on ultrasound the IUD is visualized in the uterus, she basically gets routine care. If it's not visualized, you need to do an X-ray. If on X-ray you don't see the IUD, then the diagnosis will be expulsion, and she needs, again, some form of contraception ongoing. If you do see it, this would mean that a perforation occurred at the time of insertion, and you need to proceed with laparoscopic removal because leaving it in is likely to result in increased inflammatory response at that time. What do you do with a non-fundal placement? Again, or non-fundal finding in ultrasonography. Basically, whether the patient has symptoms or is asymptomatic, it varies. If the IUD string or stem is above the internal os, certainly you can counsel her about that it may be still working. But again, if you're having symptoms of bleeding and cramping, certainly she may decide to have it removed and perhaps replaced. If the IUD string or stem rather is below the internal os, whether or not she has symptoms or not, the IUD should be removed because it is a diagnosis of partial expulsion. In an asymptomatic patient with the stem above the internal os, you would have some discussion as to no guarantee that the efficacy is exactly the same, though it probably is, but there's certainly no data to support that suggestion. What do you do if you have a positive pregnancy test with an IUD in place? You need to do an ultrasound. If you diagnose an ectopic pregnancy, you can manage them with medical or surgical management and consider leaving the IUD in afterwards as a form of contraception. If you have intrauterine pregnancy and it's undesired, the IUD can be removed at the time of the surgical abortion. If you have a desired pregnancy, you do the pelvic exam and you have to determine whether you see the IUD strings or you don't see the strings. If in fact in the patient who you're planning on doing a surgical abortion, as indicated on the top of the slide, again, if you don't see it, you need to do an X-ray to confirm whether or not a perforation has occurred or the patient expelled it. If you do see the strings, which is the next box over on the top, in a patient with a desired pregnancy, the IUD should be removed because there's an increased risk of spontaneous miscarriage. When you don't see the strings and you're no idea IUD is visualized on ultrasound in a desired pregnancy, basically you need to do the X-ray after the pregnancy to determine whether expulsion had occurred or there had been a perforation. If you see the IUD within the cervix, again, should be removed. If it's above the cervix, you do not attempt a removal, but the patient needs to be counseled. There could be an increased risk of preterm delivery or ruptured membranes. With a non-palpable implant, again, this is a challenge, and you need to determine what type there is. The recent use of the Nexplanon has changed the formulation so that there is barium sulfate implanted into the device so that you can localize it with conventional X-ray, or you can use high-frequency linear transducers, which are used to gain vascular access or to do breast biopsies. And again, you would have to use that in the older forms of the implants. You can attempt removal once localized. Again, if it's not deeply into a neurovascular bundle or into the muscle, you can do that in an outpatient setting under the local. If it is deep in the muscle or into the neurovascular bundle, one should certainly utilize a surgeon who has experience in dealing with those types of issues and who is familiar with the anatomy of the upper arm.